So we'll work out the controls here. So disclosures, just so you know, I'm involved in a number of consulting firms and neuroluminance, which we have a booth here today. You're welcome to come by. Officer on the Brain Imaging Council of Society of Nuclear Medicine, kind of unusual for a psychiatrist, and speak regularly on neuroimaging there. And president of the International Society of Applied Neuroimaging, which is a new society over the past couple of years. We're already publishing, and the goal is to sort of bring neuroimaging in fields of psychiatry and neurology into the forefront. Now, I have to disclose the FDA part. A lot of what I'm talking about is not approved by the FDA, and so what? Comorbid ADHD. Let me say one thing about the talk. There's a lot of slides. Some of these slides I am not going to dwell on. The purpose of the slides being there is so that they're on the video. Okay, so it becomes an educational tool and a reference tool for later. So I'm not going to go through each line item here. It's not necessary. But the idea about ADHD. Now, we're talking about comorbidity in autism. So you have a child who is on the spectrum, and they're hyperactive, impulsive, disorganized, interrupting. Does that mean they have ADHD? Well, no. It means they have the behavioral phenotype that we associate with ADHD. And so the concept that I want you to walk away with today, and therefore after I say this you can leave, is that we're not talking about diagnoses. We're talking about behavioral phenotypes. The DSM-5 said Asperger's doesn't exist. We just have an autism spectrum disorder now. Well, Tom Insel, the head of National Institute of Mental Health, said, I have a vote of no confidence for the DSM-5. And he says, I will fund no study based on DSM-5 criteria. If you're not using neuroimaging, if you're not using biomarkers, do not bother applying for funding at the National Institute of Mental Health. Right? I like Tom Insel. So, other features of ADHD, these are phenotypes, you recognize those. Now, what are the medications that you use to treat ADHD? Well, I'm going to list them all. I'm not going to go through them all. There's really two flavors. There's methylphenidate, Ritalin, and there's dextroamphetamine, Adderall. Now, in the old days, you go to you go to USAAA Child Psychiatry Clinic, they give you a week of each. And when you come back, they say, which one did you like better? And that's what they go with. Now we've got a little bit more to work with. Adderall is long-acting dextroamphetamine salts. So they're using pharmacology or chemistry, really, to give you a longer-acting dexedrine. Adderall XR is a capsule with little beads. Some of the beads are just Adderall, and some are Adderall with a little coat on them. The same thing's true for Metadate and Ritalin LA, just that they're using Ritalin instead of Adderall. Now, Concerta is an osmotic pump, and this is a beautiful technology. I use this technology in research. And so it's very accurate, and it delivers with 2 osmotic pumps inside this plastic capsule. The pill is a machine. That's kind of cool. Just recently, Concerta went generic, which doesn't make any sense because it's filled with Ritalin, which has been generic for 40 years, but the technology went generic. So one thing to be aware of is Mallinckrodt has a generic Concerta. It's basically Ritalin and wax. It's not an osmotic pump, so you're not going to get the same benefit from Mallinckrodt generic. Ritalin SR is, again, Ritalin and wax. Now down here is Daytrana, which is a patch, which is really cool, because you can put the patch on, and when they're done with what they need to do, you can pull the patch off, and an hour later it's gone. And it's really bad, because most of these kids on the spectrum can't tolerate the patch. Vyvanse is a long-acting form of Adderall. It has a chemical tag on it that allows it not to be abused, because the chemical tag has to be pulled off by an enzyme in your liver, and that only happens so fast. So you can take a handful of Vyvanse, and all that will happen is you'll be very alert for 48 hours. Now, there's alternatives to the stimulants, and these are really important. Anybody here ever heard of Tenex? Please raise your hand. Great. Okay. So when I used to give this talk, nobody had heard of it. So Tenex has been around for a long time. It's been generic for years. It's $8 a month. And I had amassed about 300 cases and was about to publish the case series of 10x as an augmentation strategy in ADHD in neurotypicals, when I found out that Shire Pharmaceutical was developing Intuniv, which is long-acting, notice the quote marks, 10x. Long-acting means instead of having a half-life of 14 hours, it has a half-life of 16 hours. I'm saying, okay, this is several $100s a month, this is $8 a month, which one am I going to go with? But most importantly, how does it work? It is a blocker of the alpha-2 norepinephrine or adrenaline receptor. Well, what does that mean, Doc? Well, the alpha-2 receptor is the braking mechanism. So what you actually do is you are stimulating that brake. You're pumping the brakes of the adrenaline system. That's really good for overactive and or over-aroused children. So PTSD, whatever, agitation, kids who are overloaded by sensory information, 10x works fairly well. In addition, in the brain, there are more than one type of ADHD, and I'll come back to that in a little bit, and this is where 10x is important. Clonidine is the grumpy grandfather of 10x. Clonidine is a little bit more sloppy. It works on both alpha-2 and alpha-1. Therefore, clonidine is sedating. Clonidine lasts 4 hours, so you get 1 hour of nothing, 2 hours where where they're sleepy. The third hour they're doing great. The fourth hour it wears off. Now, if anybody of you have ever had kids and they're prescribed clonidine to sleep, and you notice it's great, they go right to sleep at 8 o'clock. And at midnight, 4 hours later, they wake up. You ever seen that pattern? So this is a classic pattern that I see in my patients. Bupropion as an antidepressant inhibits both dopamine and norepinephrine reuptake. So you end up with more dopamine, which helps if you have ADHD. So this is a third-line treatment. Tricyclic antidepressants are old antidepressants, and they are, in fact, inhibitors of serotonin and norepinephrine. So increasing norepinephrine, indirectly, you're working on the alpha-2 receptor. It's often a nice strategy for kids who can't tolerate dopamine increase. It's a nice strategy. It also fixes bedwetting, and it's prophylactic for migraines, and it works well for people who have GI side effects for anxiety. And then, of course, we have Risperdal. Risperdal is the only medicine that we use in autism, right? This is what we always hear. No. But it has to be put on the list. It's a fourth-line treatment for ADHD. Now, when we look at the responses, we see something like this. Ritalin, 80%, amphetamine, 80%, atomoxetine, I'll come back to, bupropion, 58%, tricyclic, 68%. Not bad, okay? Now, what about we're really wrong about this ADHD thing. What if there's more than one form of ADHD? The DSM says there's 3 forms: inattentive type, hyperactive type, and combined type. No, I'm talking about, that's phenotype. What about in the brain? What if there are more than one kind of ADHD? I'll give you a trivial example. If you have a child who has a traumatic brain injury involving their frontal cortex, they will present with the symptoms of ADHD because their frontal cortex doesn't work properly anymore. Do they have ADHD? Is the stimulant going to work on them? Maybe not. So let me give you an example. So Kim et al., this Korean group, did a great study. 40 children diagnosed with ADHD with neuropsych testing had a SPECT scan. All the ADHD patients had decreased blood flow in the medial orbital frontal cortex. I'll show you that. Temporal gyrus, frontal gyrus, and the cerebellum. Let me show you what that looks like. So here's a SPECT scan. And a SPECT scan is a functional brain scan. And if you sit in Dr. Usler's talk, you'll learn more about these. And if a patient is at baseline, that is at rest, so to speak, they're not doing anything actively when you inject them with the isotope, you'll see a brain like this. Here's the frontal cortex. Here's the orbital frontal cortex. The eyeballs sit right about here below that. Cerebellum's right back here. This color scale is set up so that yellow and light brown are normal. Green is 1 standard deviation below the mean. Blue is 2 standard deviations below the mean. Red is 2 standard deviations above. If you look at the same patient when they're doing a concentration task, you see that their frontal cortex becomes more active. This is a normal patient. Here's someone with ADHD. Frontal cortex is active, orbital frontal cortex is active, and when they concentrate, there's a drop. It goes from yellow into green, so a full standard deviation drop here and in the frontal cortex. Okay? Now, scientifically, that's not meaningful. It's only one standard deviation. But if a patient is supposed to increase their activity in their frontal cortex by at least one standard deviation, and they go down, you now have a two standard deviation difference from the expected result. This is significant. You may be familiar with this sort of clay model rendition of SPECT scan, so I thought I'd show this to you. Here's a patient at baseline. This is the bottom of their brain. Temporal lobe should be right here. Cerebellum is here. And when they concentrate, you see this dropout, which shows up as holes in this sort of presentation in the orbital frontal cortex. So that's typical ADHD. Okay? This is what we expect. This is what responds well to the stimulants. What about this? Here we've got someone, they've got a hot brain. When they're concentrating, the brain gets hotter. They're hyperactive. They're impulsive. They can't concentrate. They're interrupting. They're silly. They're giddy. Is this ADHD? And what do you think would happen if you stimulated this brain with methylphenidate? Exactly. So I point this out because even if we look at DSM criteria for ADHD, generalized anxiety disorder, mania, depression, and conduct disorder, oppositional defiant disorder. And let me just pause for a second. Oppositional defiant disorder is the world's most ridiculous diagnosis. Let me repeat that. Oppositional defiant disorders is a ridiculous diagnosis. It's based on behavior. You're oppositional, you're defiant. Therefore, you have oppositional defiant disorder. What does this mean genetically? What does this mean neurophysiologically? What does this mean diagnostically in predicting what they'll respond to in treatment? What does this mean in terms of looking ahead into the future? If they have oppositional defiant disorder, does that mean they're going to grow up to be an antisocial personality disorder? No. It means they have untreated ADHD or untreated mania, or they have OCD and they're oppositional and defiant because you're challenging their compulsions, and they can't tolerate that. So just looking at restlessness, poor concentration, increased motor activity, distractibility, irritability, we see this huge overlap in these diagnoses. So you really have to kind of do a comprehensive evaluation, actually talk to the teacher and such and do some quantitative measures. Maybe even do not just paper and pencil tests, but a continuous performance test on a computer, and maybe even do a scan. So why? Patient 1, 5-year-old with delays in speech, limited social reciprocity, no eye contact, lack of spontaneous sharing of interest with others, obsessive, odd play, repetitive motor behaviors, anger outbursts, hyperactivity, short attention span. Sounds like our kids, right? They had a scan. The scan showed decreased cortical activity throughout the cerebral cortex, decreased perfusion in the cerebellar vermis. This is a frequent finding, decreased function in the cerebellum. So I just want to point out, diffuse overactivity is associated with impulsivity, hyperactivity, reactivity, tantrums, anger outbursts, poor attention, and Eamon and colleagues showed that it predicts a poor response to stimulant. Remember that hot brain I showed you? Yeah, it makes sense. So let's look at this guy's brain. Here's his brain. Diffuse overactivity. This is not a brain that you want to stimulate. Now, this is a different way of presenting this data, and Dr. Usler will probably explain this to you as well. Everything that's gray is in the normal range. It's plus or minus 2 standard deviations compared to a normal database. Not to itself, not to the kid himself or herself, but to a normal database. Anything that's red is 2 standard deviations, purple is 3, white is 4 standard deviations above, and going the other way, it's 2, 3, 4 standard deviations. Let me show you another patient. 10-year-old boy with delays in speech, limited social reciprocity, no eye contact, obsessive, anger outbursts, poor attention, etc., etc., etc. Same phenotype. Same outward behavior. He's participated in ABA therapy. He's had intensive school programs. Unlike patient 1, though, his scan shows patchy decreased activity, not overactivity. In other words, he looks like this. See all this green in here? Little bits of red here, but we see all this green, sort of sick-looking brain, ill brain. Let's compare the two. Overactivity, underactivity. See all the green? So 2 brains, 2 kids, exactly the same phenotype, look very different when you scan them. Let's give another example, ADHD. This is a neurotypical 7-year-old evaluated at Denver University, had a 5-day testing for $8,000, diagnosed with ADHD, and she was given Strattera. This is atomoxetine. Now, I left out Strattera in the medications because it deserves special attention. She became aggressive on Strattera. She was still having lots of trouble in school, unable to sit still, irritable about homework, impulsive. So Strattera wasn't helping much. Well, in fact, a colleague of mine, Dr. Hartman, who was up in Minnesota, we studied a total of 153 new starts on Strattera and published this back in 2004. 51 out of 153 became aggressive, violent, hypomanic. We had hospitalizations. We had juvenile detention placements. You can see the numbers. It's frightening. Verbally aggressive, physical aggression, mood swings, irritability. And what's notable is some of them had family history. Some had a personal history, like they'd gotten Zoloft and climbed water towers and ate frogs, to give an example. But there were kids who had no history whatsoever. So in kids who had no history whatsoever, there was still this activation. In other words, this is a very risky medicine to use. So let's take a look at this little girl who got aggressive on Strattera. Here's her scan in that sort of clay model presentation, baseline concentration scan. Where's that dropout? You don't see it. It's not there. Well, let's look at it a little bit differently. Here's her baseline scan. And I'm just showing you, here's the bottom, here's the top, and here's from the side. This is a hot brain. So we're not going to help it with treating it like it's ADHD. It's phenotypically presenting like ADHD, although the mood stuff points me in the direction of a mood disorder. So she was treated with trileptal, oxcarbazepine, which is the non-toxic version of Tegretol. Grades improved within 6 weeks. She's continued to improve. Now 2 years out, grades are back where they belong. Very little adjustment in the dose. Is tolerating a chaotic family situation and doing fairly well. Let me give you one other example. 10-year-old female evaluated with QEEG, diagnosed with visual and auditory attention problems, went through neurofeedback for $10,000. Evaluated by a behavioral optometrist. And have anybody ever gone to a behavioral optometrist? I'm not picking on them too much. They do some really incredible things, but you got to be careful because they almost never find nothing. They always find something. She went through vision therapy, and then she was treated with a stimulant and got agitated and anxious. Also diagnosed with auditory processing. She'd seen abuse. So there's all this stuff that says, wow, this is a really complicated case. She needs EMDR. She needs psychotherapy. She doesn't need meds. But I met her. And she's bright and she's articulate. I mean, and, 2 years beyond her age. But her math comprehension, 35th percentile. Reading comprehension, 10th percentile. She did a Connors continuous performance test in my clinic and passed with flying colors. Here's her scan. Baseline concentration. No dropout. Not even in the cerebellum. I mean, and the temporal lobes, look at this. The temporal lobes actually get better when she concentrates. So here's putting that scan into color so that holes show up as decreases in color. Remember, yellow is normal, brown is half a deviation above, red is hot or overactive, green is underactive. And what do you see? The temporal lobes are underactive. Now, the temporal lobes are kind of important. Learning, memory, emotional regulation. And how can you increase the function in the temporal lobes? Well, what's the neurotransmitter of learning and memory? Acetylcholine. So to increase acetylcholine, we pull out what? An SSRI? No, that's serotonin. We pull out Risperdal. No, that's dopamine. We pull out a stimulant. No, that's dopamine as well. Aricept is the only thing that increases acetylcholine. Aricept is used to treat Alzheimer's disease, right? So I started on Aricept. 1 month later, reading speed picked up, math speed picked up. 3 months later, she'd gained 2 years in math skills and has continued to do well. All right, so ADHD is a behavioral phenotype. Let's talk about OCD. OCD is probably one of the most neurobiologically pure disorders. So in kids who have autism and OCD behaviors, you really want to look at their neurobiology. So let's take a peek. So the brain on OCD, there's some classic findings that you'll see. One is, here's a horizontal section through the brain, and this is a frontal section. So this is a loaf of bread, and this is a ham, if you like. So we're looking at the very front here. This part here corresponds to this part right here. This is the anterior cingulate gyrus. In OCD, the anterior cingulate gyrus, which is the part of our brain that allows us to shift from this to this, is overactive. And for whatever reason, overactive means you can't do that. You also see that the frontal cortex is overactive, and you'll see here that the basal ganglia are overactive. What does that mean? Well, forgive the neurobiology, but it comes naturally to me. So here's the front of the brain, here's the back of the brain, cerebellum, brainstem. And the putamen and the caudate, and caudate starts here and loops around and ends up connecting up to the amygdala. And for those of you who didn't spend 5 years getting a PhD in neurobiology, the amygdala is sort of our little emotional center. It's the center of anxiety and emotional regulation. It's the thing that puts the emotional tag on experiences. Therefore, it's the thing that we're addressing when we do EMDR. Because what's EMDR? EMDR is a process by which you strip off the emotional valence from a memory, from an experience. That's how it becomes non-traumatizing anymore. That takes place in the amygdala. Different lecture. So in OCD, what happens is the frontal cortex gets an idea, and mostly through the anterior cingulate, it goes through the caudate, and then from the caudate it goes to the thalamus, and then it goes back to the frontal cortex. And you literally create this reverberating loop. And that just goes on and on and on. And so looking at perfusion and studies of the brain, and here we have Lucy et al. Using SPECT in OCD and saw that increased blood flow in the bilateral anterior cingulate and left caudate. Okay, these are anterior cingulate, caudate. Diller looked using SPECT in children, 18 children, increased activity in the bilateral caudate, anterior cingulate gyrus, and the prefrontal cortex. Okay, all right, so SPECT is showing this, but you know what they say. You know, you talk to these neurologists and other psychiatrists, and so they say, SPECT is old technology. Nobody uses SPECT, or they'll say, well, so SPECT is experimental. It's not ready for prime time. We'll often hear this. Well, the archives of neuropsychiatry this month are publishing 10, count them, 10 articles on the application of SPECT in the diagnosis and differentiation of anxiety, ADHD, depression versus dementia, etc. So some very exciting stuff coming out. Now, so maybe SPECT isn't so good. Let's look at PET. So Rausch et al. Did a study, 11 patients, FDG PET. The OCD patients had reduced activity in the posterior cingulate and basal ganglia after they went in surgically and cut their cingulate. But before that, they were very hot. So one treatment for OCD is surgery, and there's some exciting stuff now. They've just now approved doing deep brain stimulation for OCD, which means you run an electrode down, and then you can do a little firing, and it literally turns off OCD. Very exciting stuff. I'm working with the university on a couple of cases on that. But just to drive home the point, here's some more SPEC studies. OCD again, increased blood flow, anterior cingulate, prefrontal cortex, bilateral caudate. And here's a PET study showing the same thing. Okay, do you believe me now? So the last time I gave that series of slides, I was at the American Psychiatric Association meeting. And afterwards, the response was, no, we don't believe you. SPECT has no use in the diagnosis of OCD. But let's take a look, putting it all together. Here's a kiddo who came in. He'd been treated for ADHD for years with not so good results. But look at the anterior cingulate. Look at the caudate, overactive. We don't have the frontal cortex, so we don't have the triad. When you look at this picture, and this is comparing his brain to himself, okay? This is what you'll get if you look at those clay models or those glass brains, or you look at this sort of thing. It's comparing the patient to himself. Now let's compare the patient to the normal database. And what do you see? The frontal cortex is red hot, and the insula is red hot. So the areas involved in exactly OCD and emotional regulation are red hot. All right, so let's talk about treatment. I've spent some time on diagnosis to get you thinking along the lines of we have to diagnose based on neurobiology, not behavioral output. Because the kid running around the store who's not listening and impulsive and zipping back and forth may not have ADHD. He may have extreme anxiety. He may have OCD that says all of the cans have to be lined up. He may have mercury poisoning. He may have aluminum poisoning. Or what I see in Colorado is cadmium poisoning out in the frontier areas where they're pulling well water loaded with cadmium. All right, so treatment of anxiety. If you go to Joe Blow, psychiatrist, and you say, Doc, I got anxiety, or you go to a dentist these days, they'll give you Valium or Xanax or Ativan. These are benzodiazepines. These are alcohol in a pill. So what do you think happens if you give a child alcohol? You're going to disinhibit them. And this is what I almost always see, is they'll get sedated for a while and things will be great, and then they're disinhibited and tearing apart the room. So benzos are not a good idea in children, and frankly, in my opinion, not a good idea in adults. The SSRIs, they're considered first line for treatment, but they're only about 45% effective in some studies, and in the meta-analyses, it drops considerably. It's about 1 in 16. Also, SSRIs can increase anxiety at first, which is always fun. Effexor, which is a SNRI, so it's serotonin and norepinephrine reuptake inhibitor. It's useful in some cases. Some people have a lot of side effects with it. Some people get activated with it. Some people get horribly sedated with it. Buspar. Buspar has been around for a long time. It was invented to sort of replace Valium. It works on the serotonin 1A receptor. It's a partial agonist, which is a cool little thing. That is that if there's a whole bunch of serotonin around, it blocks. If there's not enough serotonin around, it stimulates. So it kind of can do two things at once. Very safe medicine. The major problem with Buspar is most people underdose it. So they start at, it comes as a 10 or a 15 milligram pill. They start at 10 milligrams twice a day. And if nothing happens, they say, okay, it didn't work. Go on to the next medicine. Now, when I was at Washington University in St. Louis, I treated the heart transplant patients. They'd fly them in, give them a pager, put them in an apartment, and say, okay, here's your pager. When the pager goes off, you have 1 hour to get to the hospital to get your new heart. Have a nice day. So they come in very anxious on lots of meds with bad tickers and bad lungs and bad livers and kidneys. And Buspar worked very well for that, and it plays well with other meds. The other thing that I use this is beyond this lecture, but I think we see it a lot in this population, is trichotillomania, hair pulling, or skin picking. Now, the real cool thing is that, for whatever reason, Buspar helps to turn that off. But it's not going to happen at 10 milligrams twice a day. You have to work it up. It might be 30 milligrams twice a day. It might be 40 milligrams twice a day. But it will help. So the highest I've gone in a child is 60 milligrams twice a day. And he was doing gymnastics, high bar gymnastics. But prior, and not dizzy, not sleepy, and not falling off the high bar, but prior to hitting 60, he wouldn't leave the house unless he was carrying a plastic sword because the bugs would get him. Now he doesn't worry about the bugs. Let me talk about Cerazone. This is my big gun for OCD. So we're back to OCD, but it's also great medicine for anxiety. It's an underappreciated and somewhat blackballed medicine. It is a specific blocker of the serotonin 2A receptor. The 2A receptor is your anxiety receptor. If I could take a pin and poke Arnold Schwarzenegger's 2A receptor, I could make him anxious. You know, that joke used to be funnier. Since he become governor, it's lost its zing. I need a new guy. Anyways, Cerazone is often referred to as an SSRI, a serotonin reuptake inhibitor. 1 hour, it's an SSRI. Then it's exclusively a 2A receptor blocker. I have a case series sitting in a box that I tried to publish about 10 years ago, and I'll tell you why. Where I showed that it was 90% effective in OCD. And I find that it's 90% effective in anxiety in all cases except geriatric psychiatry, which is a different animal. The reason it didn't get published is because there's a little black cloud hanging over Cerazone, and that is that it's purported to cause liver failure. Oh, great. Let's not give that to my child. But the risk of liver failure is 1 in 300,000 patient years. The risk of liver failure with Depakote is 1 in 20,000 exposures. So magnitudes of difference. The reason the liver failure occurs is apparently an allergic hepatitis. So if it doesn't happen the first 6 weeks, probably not going to happen. Now, I have patients, lots of patients on Cerazone. Every time they say they're going to stop making Cerazone, I get these frantic phone calls. What am I going to do without Cerazone, doc? It's the only thing that works. So this is a very powerful medicine. It has to be used judiciously. I don't use it first line because safest medicine first. But a very important medicine for treating anxiety. All right, OCD and anxiety. Another medicine is anafranil, clomipramine. This is sort of, standard psychiatry considers this the gold standard. It's a very strong SSRI. It only works in about 65% of the cases. You had to measure blood levels because it is toxic. But it's useful. Gabatril. Gabatril is a anticonvulsant. It's a seizure medicine. And I was very excited when it came out because all of us who are talking about this, about 30,000 psychiatrists on a psychopharm listserv all over the country, we were seeing this. It's a specific blocker of GABA uptake. So you're increasing GABA. GABA is the calming neurotransmitter. This is cool. There's only one problem. Patients get seizures on this medicine. Now, we knew that going in, so I was able to talk to all my patients and said, let's try Gabatril. And, you know, I had 3 or 4 who developed partial complex seizures on it. That went away as soon as we stopped the medicine, but if I hadn't talked to the parents ahead of time and said, look, this is a risk, it would have been a little dicey. But since they knew what was going on, they said, oh, that's what that is. Okay, call the doc, stop the medicine, all will be good. All right, Neurontin, another anticonvulsant. This is a medicine to learn about. This is why there's all that blah, blah, blah on the slide. You don't have to read it, and I won't say it all. Neurontin is a partial blocker of voltage-gated calcium channels. Okay? It doesn't work on neurotransmitters. It works directly on the calcium channels on the nerve axons. And voltage-gated calcium channels are more plentiful on little axons than they are on big fat axons. So little axons like pain fibers and the fibers that connect different parts of the cortex, and incidentally, the fibers that are involved in anxiety, all have more voltage-gated calcium channels. So Neurontin works very well for anxiety. Now, the studies are really being done using Lyrica, which is pregabalin, and the reason is that Lyrica is still under patent and Neurontin is not. And the studies are showing, for example, Hidalgo did a meta-analysis, and they showed that the effect size of Buspar, let's take Buspar, was 0.017 or 0.17, so pretty low. The effect size of the SSRIs was 0.36. The effect size of the benzos was 0.38, and the effect size of pregabalin, which I misspelled, which is Lyrica, was 0.5. Okay? In my hands, 80% of my patients respond to Neurontin, which is $30 a month, as opposed to Lyrica, which is $600 a month, and no insurance company will authorize it. So Neurontin is a powerful tool in fighting anxiety that not many psychiatrists are using. But if you're a neurobiologist, you sort of think that way. Treatment of depression. We got the standard players, the SSRIs. You know them all. Tricyclic antidepressants, nortriptyline, amitriptyline, imipramine, dizipramine. And again, tricyclics in tiny little doses are prophylactic for migraines, including abdominal migraines. They're prophylactic for the GI side effects of SSRIs. They're prophylactic for the GI symptoms of anxiety. So if your child is so anxious that every Sunday they start complaining about stomach pain, and Monday through Friday they complain about stomach pain, and Friday night and Saturday and most of Sunday they do great, and then Sunday night before school starts they're complaining of stomach pain again, amitriptyline. Because it works on blocking the particular serotonin receptors that are responsible for that in your gut. Your gut's loaded with serotonin receptors, by the way. Effexor, we've talked about that a little bit, so I won't say too much about that, other than Effexor and its friend Cymbalta are a real pain to get off of, because people have discontinuation syndrome. For whatever reason, your body just doesn't like having that reuptake turned off. Wellbutrin, Remeron, Serotonin for depression. MAOIs are sort of the big guns. You had to restrict your diet, avoid certain meds, not used too often. St. John's wort, light therapy. And this is really important in seasonal affective disorder. I see this a lot in Denver. I never saw it in Seattle because no one ever saw the sun, so they didn't have anything to compare to. ECT is, if you're ever on Jeopardy and they say, what's the most effective treatment for your, depression, the answer is ECT. Okay? It's about 75 to 80% effective. Now, in our hands, in our ketamine clinic, Neuroluminance's ketamine clinic, using a neurobiologically based protocol, not the standard protocol that everyone else is doing, but a neurobiologically based protocol, we have a 90% response rate. Now, I just had to take a little aside to Dr. Hu's talk, because ketamine does some very interesting things. It activates brain-derived neurotrophic factor. Brain-derived neurotrophic factor is a repair factor in your brain. It repairs synapses, dendrites, rebuilds circuits, actually induces pluripotent stem cells to differentiate into neurons. Now, whether they get to where they belong or not is a great question, but it does all these things. And it affects inflammation. It affects cytokine balances. And the connection between the brain and inflammation is all in the cytokines. So ketamine is a very interesting medicine that's just now, it's being looked at as depression, and the ivory tower types are saying, oh, no, it's dangerous, and it's going to cause hallucinations. And I've seen zero hallucinations in my patients. But I'm fascinated, particularly given what Dr. Hu taught me today, about where this might go. Now, there's talk about intranasal ketamine, and I just got to say one thing about this, because people are saying, wow, this is really cool. There's no needles. There's one problem with intranasal ketamine. Ketamine lasts about 8 minutes in your body. The whole point of ketamine is time on the receptor. The longer it sits on the receptor, the more likely you're activating brain-derived neurotrophic factor. In fact, WashU is doing a study, 48-hour infusions. Can you imagine? You don't want to be in that placebo group. But time on the receptor. So when you do intranasal ketamine, number one, you get 8 minutes, and number two, it all gets cleared by your kidney into your bladder, and the most common complication, it's running about 20-25% Colorado area from my colleagues who are using this intranasal ketamine is bleeding and blistering and mucus discharge and all sorts of bad things going on in the bladder. Okay? So when people ask me, what do you think about intranasal ketamine? My answer is, well, do you like your bladder? Lithium. Let's switch to talking about mood disorders, because I've hinted that there's this mix between what's ADHD and what's mood dysregulation, and now we've got this new anger dysregulation disorder of childhood in the DSM-5. Give me a break. But at least it's better than everybody has bipolar 1. Papalos is the bipolar child. I wasn't aware that fear of clowns was a indication of bipolar disorder until I read that book. Apparently it is. I mean, I swear when I read the book, I said, this is Asperger's. Now, Papalos is a great psychopharmacologist. The book is great. I just don't agree with chapter 1 and 2. Lithium is a very interesting mood stabilizer. We have no idea how it works after 70 years. It's a metal. It's just a metal. It can be toxic. It's cleared by your kidneys. So your kidneys are trying to get it out, so you're making more urine, so therefore you're peeing more. Sorry, I'm a child psychiatrist. And you're drinking more. It can affect thyroid function. It's not a good idea early in pregnancy, but after the first trimester, it's really the gold standard. But talking about autism, it's like, where does lithium fit in? That's a great question. Kind of way down the line in my book, but it's important to talk about it. Depakote, another mood stabilizer, not my first choice. It's toxic. You have to monitor blood levels. It'll affect your liver function. It'll lower white blood cell count. It'll lower platelet count. Everyone gains weight. I loved it when Zyprexa first came out, and everyone said, oh, I got a great idea. Let's give the child Zyprexa and Depakote. And they come back at the next visit, and they've doubled in size. And I'm really not kidding. Nausea, tremor, headache, hair loss, or side effects. Hair loss is just because we're deficient in selenium, and we can fix that. Tegretol. Now, according to the American Academy of Child and Adolescent Psychiatry, this is a third-choice mood stabilizer. It's really pretty good. I'd put it long before I'd use Depakote. Trileptal, probably my favorite medicine in the mood stabilizing category. For children, non-toxic, no effect on liver, white blood cell count, well tolerated. If they get dizziness and nausea, it just means I'm going too fast, and so I back the dose down. There's a small risk of hyponatremia, lowering the sodium content. This is more common in kids than it is in adults. There's one study done, Karen Deneen Wagner in Texas did a study of children with bipolar disorder using Trileptal and found that it was non-significant. But her definition of children was 6 to 18. And I showed her this on her poster. If you look at 6 to 13, it's working like a charm. 13 to 18, nothing. So the older kids of non-effect swamped out the positive effect that we see in the younger kids. Neurontin. It's an anticonvulsant. It's a very mild mood stabilizer as well. Also works on anxiety and neurogenic pain. So you sort of have this combination of things, and you want to try something mild, and you've got a kid who's anxious, and they have mood dysregulation. Okay, these kids are not comorbid for one thing. If you're on the spectrum, you often have several things going on. So it's not unusual to say, okay, how can I kill 3 birds with 1 stone? Lamictal, lamotrigine, very promising medicine, great in adults. I don't start with it in children because the risk of Stephen Johnson's rash, which is a very severe, life-threatening rash, is 25 times higher in kids than it is in adults. And then, of course, there's the atypical antipsychotics, which have spent a lot of money getting themselves positioned to be mood stabilizers. Now, so what are the atypicals? Olanzapine, and I just put here, the studies that show that they actually do something in mood stabilizer. Zyprexa, ziprasidone, Geodon, quetiapine, Seroquel, Risperdal is risperidone, and then several studies that were done in the RUP studies, just which you guys know. And this is where they kind of get at this whole idea that, okay, here's a treatment for autism. Risperdal is the only FDA, well, Risperdal and Risperdal and Abilify, excuse me, are the only FDA-approved treatments for autism. It's true. But it's for aggression in autism, not autism. So if you want to do chemical restraint, then that's a way to do it. Now, there are times when that's useful. I'm not saying don't ever use Risperdal. I'm saying don't start Risperdal and wait 12 years to think about changing, because there are other ways to look at it. And I'll come back to Risperdal in just a minute, because I want to talk about learning disorders. Learning disorders in general are a big problem in the U.S. 85% of the people who are incarcerated have a learning disorder. It's a significant issue in autism for a variety of reasons. Here's the definition given by the National Committee of Learning Disorders. Not very helpful. When you look at how learning works, you get input into the brain through perception and sensory processing. Okay, if you're on the spectrum, you're already in trouble. That goes through the thalamus, and then it goes to primary sensory cortex into secondary sensory cortex, and then it goes into memory formation, comparison to learned information, to say how is this the same or different from what I learned before, sequential and organizational processing. Okay, we're in trouble again. Concept formation. Remember this, I don't know if you were in the other talk this morning, up, down, behind. You should know that by 18 months. A lot of kids on the spectrum don't. So, okay, we're already in trouble. And then output, motor learning, speech, writing. And writing and speech are very complicated tasks. They involve large portions of the brain. Here's what we have in the DSM-4. I don't really care what the DSM-5 has to say. Dyslexia is a good model. They'll have normal verbal IQ, normal performance IQ, no obvious impairments. There's a genetic inheritance. But when you look at their temporal lobes, I'm going to skip this and look at their temporal lobes and show you, here's one side versus the other. This is which side of the brain, guys? Everybody has to raise their hand a little bit. It's left side, right? This is, for a right-hand dominant person, this is the part of our brain that processes language. So this, the planar temporale, is bigger on the left side. In kids with dyslexia, that's not true. Now, when you do a search for learning disorder treatments, Medline search for pharmacotherapy, you get 19 references. It hasn't changed much since 2003. So let's look at a couple of kids. Here's a guy, normal IQ, verbal subscale performance is a little bit lower, and he was 16 at the time. He was diagnosed with a receptive expressive language disorder, and you can see the split here, performance and verbal. He would get lost in the school. His speech was disjointed. He could not string a sentence together. He could not say, the dog jumped over the red fox. It would be the dog, fox jumped, or something like that. Started him on Seroquel. Okay, this is an atypical antipsychotic, but at 25 to 50 milligrams. He came back 2 weeks later and said, Doc, it's like the smart guy in me has come out to help. So just a little bit of an antipsychotic isn't always a bad thing. Here's another example. 12-year-old white female, mixed receptive expressive language. This one's not on the spectrum. Started Seroquel, went up to 200 milligrams twice a day, so a big dose. There was a moderate improvement in her sequential language, and I believe I have one more example. Yeah, so a nonverbal learning disorder case. You can see the verbal performance split. Started on a Risperdal 0.5, no longer getting lost in school. His grades shot up to A's, better social skills. About 6 months, we went to 1 milligram QHS. His social skills got so good, he was elected to student council. This is a kid who had been bullied his whole life. All right, let's talk about alternative hypotheses. We got a few minutes left. Oxytocin deficiency. Oxytocin is the hormone that is released during lactation, particularly by nipple stimulation, and it induces maternal behavior. If you, next slide. If you look at some of the trials that have been done in adult males, they gave fathers of preschoolers intranasal oxytocin and saw that their nurturing behavior in a laboratory preschool improved. So everybody sign your husbands up. In children, there have been several open-label trials. Sikic, who incidentally went to WashU, was in the same lab I was in, and I've been following around ever since. She saw increased social behavior and cooperation in children treated with oxytocin, and it kept going for 3 months after they stopped the oxytocin. Thank you. The oxytocin improved reading the mind and the eyes test. You know this test? It's a test that's used for fMRI studies. It increased the ability of children to make nonverbal judgments during an fMRI test, and you see increase in the medial prefrontal cortex activity with that. So this is an interesting thing to explore. And some of my children respond. About 50% had better eye contact, increased socialization, increased cooperation. Postmortem neuroinflammation. We're back to Dr. Hu introduced Vargas's information, which was that in postmortem studies, there is microglial activation in the temporal lobes and the cerebellum. PET studies using a marker for inflammation have shown increased microglial, in other words, neuroinflammatory cells in various parts of the brain. Terbutaline induces microglial activation in infant mice, and they develop behavior that looks very much like autism. So what if we're making the wrong assumption? Here's a 10-year-old boy with delays in speech, some of the same sort of things. I mean, literally the same sort of thing. His brain map showed really patchy decreased activity. This is a brain under attack, right? I mean, it's a toxic brain. Patchy blue, patchy decreased function all over. It's something systemic. So it's not dissimilar to chronic fatigue, which is also a viral illness. And so we started him on antiviral therapy, and he got tremendously better. Increased eye contact, increased social reciprocity. Let's see. And the case report, you can pick up a case report in our booth of a boy who was diagnosed with bipolar disorder, ADHD, and autism. He'd been at Children's Hospital for 7 admissions, I believe. He'd been diagnosed with the ADOS 3 times as having autism. His sister had chronic fatigue, and I had treated her with an antiviral. And so we started him on an antiviral, and all of the autistic symptoms went away. His mood disorder got better. His ADHD got better. We cut his dose of all his meds in half. He got off the antipsychotic. He's just on Lamictal and a little bit of Adderall. And just graduated high school, and he's headed off to college. This is a kid who spent hours and several rolls of tape a day taping webs all over the house. That was his obsession. And one last little bit. A 10-year-old boy diagnosed with Asperger's, sudden onset of visual hallucinations. Why is my shirt on the ceiling? He's jumping up to grab the shirt off the ceiling. I sent him to the University of Colorado Child Psychiatry Clinic to be evaluated for childhood schizophrenia. They said, nope, he doesn't have any schizophrenia. He got food testing. He's positive for egg whites, positive for mustard seed, positive for soy, positive for pineapple. They got rid of all that and it went away. But guess what? If he eats a hot dog with some mustard seed in it, he hallucinates. Right? Some alternative hypotheses, broadening your horizons. Think outside the box. Because every great advance in science is issued from a new audacity. Imagination. So we had to imagine a little bit differently. We don't have to be stuck in the biomedical model. We had to stretch into not just traditional psychiatry. All right? Thanks a lot.